Imagine taking, everyday asthma inhaler or a standard arthritis medication and inadvertently handing the bacteria living on your skin the exact blueprints they need to build an impenetrable fortress inside your body.
I mean, it sounds completely like science fiction.
Right, but is a biological reality, and it's happening right beneath our skin. Usually when we talk about a medical diagnosis, there's this expectation of precision.
Yeah, totally.
Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken.
It's binary. And, well, we find comfort in that. We like our medical issues to be visible, neatly categorized, and easily treated with a standardized protocol.
Exactly. But
Yeah.
then you step into the world of immunology, dermatology, and the microbiome, and suddenly that x-ray machine is broken. We are looking at a diagnostic landscape that is incredibly murky.
Very murky and highly complex.
Yeah, so today's deep dive is going to take us into some of the most fascinating, complex waters we've ever explored. We are unpacking a highly specific medical intersection, how taking chronic systemic corticosteroids, which, millions of people take every single day.
Literally millions, yeah.
Right. How taking those completely changes the hidden risks of getting intimate dermal fillers like penile or labial enhancements.
And, it might sound like a niche topic on the surface, but the biological mechanics behind this are universal.
Right.
To really understand what is happening here, we have to synthesize a lot of different fields. We're pulling together aesthetic dermatology guidelines, heavy-hitting immunology research on macrophage behavior, and microbiological data on how bacterial colonies react physically to human medications.
And I want to say right up front to you listening, even if you aren't in the market for an intimate filler, understanding how a common anti-inflammatory drug can accidentally team up with stealthy bacteria it will fundamentally change how you view your body's immune system and any medical procedure you might get in the future.
It really reframes everything.
Okay, let's unpack this, starting with the physical environment we are dealing with. Because getting a filler in these intimate areas carries entirely different elevated risks compared to, say, smoothing out a wrinkle on your forehead or plumping your lips.
Yeah, you really have to look closely at the local anatomy. Intimate filler procedures, things like penile girth enhancement or a labial puff, usually involve injecting a substance like hyaluronic acid.
Often just called HA. Right?
Exactly, HA. Injecting that deep into the subcutaneous tissue. But unlike the face, these areas are overwhelmingly vascular.
So lots of blood vessels.
An incredibly dense network of them, high tissue sensitivity, and highly complex lymphatic drainage systems.
So getting a filler here isn't just, lip filler down south. Because of that intense vascularity, it's like doing construction on a major, heavily trafficked interstate highway rather than a quiet suburban cul-de-sac.
That's a great way to picture it, and the clinical data completely supports that visualization.
The stakes for a microscopic contaminant are just much higher.
Right. Oh, absolutely. There is a surprisingly high complication rate associated with these specific anatomical regions. For penile fillers, studies report a baseline 8% infection rate.
Wow, 8%. That seems high.
It is. And on top of that, there's a 5% rate of granuloma formation.
Remind us what a granuloma is again.
Oh, right. Those are hard, inflamed nodules of immune cells trying to wall off a problem. And then there's a 12% rate of the filler physically migrating away from the injection site due to the mechanical forces in the area.
12% migration. Wow.
Yeah, and even a 2% risk of severe tissue necrosis.
Tissue necrosis being the actual death of the tissue, right? Because if you accidentally inject that thick HA directly into one of those major blood vessels, it blocks the blood supply.
Right, it physically occludes the vessel.
And the surrounding tissue literally starts to die from oxygen starvation.
Which is an absolute medical emergency.
Yeah.
And it's why dermatological guidelines outline incredibly strict contraindications before anyone even considers a procedure like a labial puff.
Like what kind of contraindications?
Well, if a patient has an active infection, an active herpes outbreak, undiagnosed localized pain, or specific autoimmune conditions, the procedure just cannot happen. The margin for error is simply too small.
And if things go wrong, they can escalate with terrifying speed. There's a case study that really highlights this involving a 29-year-old man, totally fit and healthy, who underwent a non-clinical penile augmentation.
Yeah, that case is alarming.
Just 10 days after the procedure, he was rushed to an emergency department with rapid onset sepsis.
And his clinical presentation was extreme. I mean, he had a fever of 38.9 degrees Celsius over 102 Fahrenheit. His pulse was racing at 130 beats per minute, and he had severe localized swelling, radiating heat, and intense pain.
To develop sepsis from a cosmetic filler is wild. I mean, sepsis isn't just an infection, it's the body's massive systemic panicked response to an infection where your own immune system starts damaging your organ.
Exactly, it's a cascade effect.
And the localized infection was spreading so aggressively that the erythema, the visible red rash of the infection, was already migrating all the way up to his scrotum within just a few days.
Right, and this is a textbook example of an acute hot infection. A needle breaches the skin, introduces a massive bacterial load directly into the vascular tissue, and the bacteria immediately start multiplying rapidly.
So it's an immediate war.
Precisely. The body sounds the alarm, you get a high fever, and you treat it aggressively with immediate intravenous antibiotics.
Now, that acute scenario makes logical sense to us. But as we dig into the microbiology, the acute infections aren't actually the most complex problem.
Not at all.
The real threat outlined in the clinical data revolves around delayed infections. We are talking about complications that erupt months or even a full year after the needle has left the skin.
Yeah, which is terrifying for patients.
How on earth does a localized filler cause a massive infection a year later?
The answer lies in a microscopic survival mechanism called a biofilm. Biofilms perfectly bridge the gap between a seemingly successful injection today and a severe, localized complication that sends a patient to the hospital next year.
Let's break down the mechanics of a biofilm, because this challenges everything we usually think about how bacteria operate. Whenever a needle breaches the dermal barrier, no matter how rigorously you sterilize the surface of the skin, it can physically drag resident skin flora deep into the underlying tissue.
Exactly.
And we are talking about normal bacteria, right? Things that usually live peacefully on our epidermis.
Yeah, common resident flora like Staphylococcus epidermidis or Cutibacterium acnes, in their normal environment on the surface of your skin, they are harmless, even beneficial.
Right.
But when the mechanical action of a needle pushes them down into the subcutaneous layers and deposits them right onto the foreign synthetic material of the hyaluronic acid filler, their behavior undergoes a radical shift.
Instead of floating around in a planktonic state, rapidly dividing and causing that hot, angry, acute infection like the 29-year-old man experienced, these opportunistic bacteria get quiet.
Very quiet.
They adhere to the surface of the filler, stick together, and begin secreting a three-dimensional protective polymeric shield. They literally construct a microscopic bunker.
And inside this bunker, the biofilm matrix, the bacteria, completely change their metabolic profile. They transition into a dormant, low-grade state.
So they basically go to sleep.
Kind of,
Yeah.
yeah. They stop rapidly dividing and they stop releasing massive amounts of toxins. And because they go metabolically quiet, your immune system doesn't immediately recognize a massive threat.
Wow.
So there is no high fever, no sudden extreme pain, no immediate red flags.
But they are far from harmless. Because of that three-dimensional polymeric shield, the bacteria inside become nearly invincible to standard treatments. The clinical measurements on this are staggering.
They really are.
Once bacteria have successfully formed a biofilm, it can require up to 32 times the normal concentration of antibiotics to kill them, compared to those same bacteria floating freely outside the biofilm.
Standard oral antibiotics just become practically useless. The polymeric shield acts as a physical barrier that the antibiotic molecules struggle to penetrate.
It just blocks them out.
Exactly. And furthermore, most antibiotics work by targeting active cellular processes like cell wall synthesis or DNA replication. Because the bacteria inside the biofilm are in that dormant, hibernating state, the antibiotics simply have no active processes to disrupt.
So the biofilm just sits there on the filler, completely dormant and undetected.
Until something wakes it up.
Right.
Months or years down the line, a trigger occurs. It could be physical trauma to the area. It could be a systemic illness like the flu that shifts the immune landscape. It can even be something as seemingly unrelated as a routine dental cleaning.
A dental cleaning.
Yeah.
Seriously.
Yeah, a dental cleaning is a classic trigger because scraping the teeth often releases a small amount of oral bacteria into the bloodstream, a state called transient bacteremia.
I see.
When those circulating bacteria or inflammatory signals reach the dormant biofilm, it acts as an alarm clock. The biofilm wakes up, the bacteria become metabolically active again, and suddenly the patient develops late-onset nodules, chronic persistent inflammation, or sudden, localized abscesses right over their old filler.
Okay, I need to push back on the timeline here. If these resident skin bacteria are just sitting in the tissue, slowly building a three-dimensional shield over the course of days or weeks, why isn't our immune system clearing them out before the bunker is finished?
That's the critical question.
Right. We have an entire system designed specifically to eat foreign invaders the second they enter the body. Why is the body just standing by and letting them lay the bricks?
Well, in a healthy baseline immune system, the body wouldn't let them build the bunker. The immune response would recognize the foreign invader and clear it out while it was still vulnerable.
Okay, so what changes?
The problem arises, and that perfect system completely falls apart when the patient's immune system has been chemically handcuffed. And that brings us to the specific intersection of this analysis: patients who are taking chronic systemic corticosteroids.
Corticosteroids are incredibly powerful, ubiquitous anti-inflammatory drugs. We are talking about medications prescribed for a massive range of conditions: autoimmune disorders, severe asthma, chronic obstructive pulmonary disease.
Yeah, drugs like budesonide, fluticasone, propionate, prednisone.
Right. They are absolute lifesavers for managing chronic destructive inflammation, but they achieve that by fundamentally altering normal wound healing and immune responses at the cellular level.
To understand the danger, we have to look at how these drugs target specific cellular defenders. Our tissues are constantly patrolled by specialized immune cells called macrophages.
And macrophages are the effector guardians of the body, right?
Exactly. They physically roam through the tissue matrix, recognize invading pathogens or dead cellular debris, and phagocytose them, meaning they literally engulf, eat, and destroy the threat.
But when you introduce synthetic glucocorticoids, corticosteroids, into the human system, they profoundly alter how those macrophages operate. These drugs enter the macrophage and inhibit the cellular induction of nitric oxide.
And nitric oxide isn't just some signaling molecule.
Right. It is a highly reactive chemical weapon that macrophages use to melt the cell walls of the bacteria they've engulfed.
So the drugs basically disarm the macrophage's primary weapon. And on top of that, corticosteroids drastically reduce the release of pro-inflammatory cytokines, specifically one called IL-8, by anywhere from 15 to 50%.
And what does IL-8 do?
IL-8 acts as a chemical distress flare. When a macrophage finds an infection it can't handle, it pumps out IL-8 to call for systemic backup. By suppressing that signal, the steroid ensures no reinforcements arrive.
But it goes even deeper than just disarming them, doesn't it?
Yeah.
Corticosteroids actually force the macrophages to undergo a complete phenotypic shift.
They do, yeah.
Normally, when a pathogen is detected in the tissue, macrophages adopt a highly aggressive pathogen-fighting state known in immunology as the M1 state. But corticosteroids bind to intracellular receptors and alter gene transcription to force the macrophages to shift away from M1 and into an M2 state.
Right, and the M2 state is biologically designed for anti-inflammatory action and tissue repair, not combat. It's what the body normally shifts into after an infection is already defeated to clean up the debris and heal the damage.
It's like having a team of highly trained, aggressive bouncers at a nightclub ready to throw out any threats. But when corticosteroids flood the system, they force the bouncers to put on blindfolds and hand out warm towels instead of kicking out the troublemakers.
That is exactly what happens. The guards are completely pacified while the invasion is happening. And if we connect this to the bigger picture, the sheer danger of implanting foreign material like hyaluronic acid into an immunosuppressed patient becomes obvious.
The bouncers are just handing out towels.
Right. The macrophages are locked in this M2 tissue repair mode. They lose their ability to properly recognize the bacteria dragged in by the needle, they can't call for backup without IL-8, and they don't have the nitric oxide to kill the bacteria even if they tried.
Wow.
So the opportunistic skin flora have absolute free rein to sit on the filler and slowly build their biofilm fortress, completely unbothered by the body's pacified security guards.
I mean, putting the immune system to sleep while a fortress is being built is a terrifying clinical scenario, but the microbiological data reveals a plot twist that is infinitely worse.
Oh, it gets so much worse.
The corticosteroids don't just pacify the immune system and ignore the bacteria. They actively help the bacteria build the biofilm.
The dynamic between human drugs and bacterial biology here is astonishing. Researchers have studied this interaction closely using Pseudomonas aeruginosa, which is a very common, highly adaptive, opportunistic pathogen. And they discovered a direct physical interaction between the steroid medication molecules and the bacterial cells themselves.
Here's where it gets really interesting. Corticosteroids like budesonide and fluticasone are highly hydrophobic molecules. They repel water, but they have a high affinity for lipids fats.
Yes, they possess high log p-values, which is the chemical measurement of how easily a molecule dissolves into lipids. And because the outer cell membranes of bacteria are composed primarily of lipid bilayers, these corticosteroid molecules don't just float past the bacteria.
They dive right in.
They diffuse directly into the bacterial envelope. They physically wedge themselves into the lipid membrane of the pathogen.
And by wedging into the membrane, the steroid physically alters its structure, increasing its fluidity. The bacterial wall gets loose and wobbly, and the bacteria do not like that physical instability.
Not at all.
It causes a phenomenon known as cell envelope stress. The bacteria physically feel their outer wall losing its structural integrity because of the human drug, and it triggers a massive molecular panic button inside the bacterial cell.
This mechanical stress initiates a highly specific, cascading genetic signaling pathway. First, the stress causes an immediate initial increase in the expression of a gene called MuCA.
And UCA is the trigger.
Yes. The alteration of this gene's activity sets off a chain reaction that results in the rapid intracellular accumulation of a signaling molecule called CDI-GMP.
So CDI-GMP acts as the master switch for the entire bacterial colony. It is a secondary messenger system that essentially broadcasts an emergency command. When CDI-GMP levels spike, it commands the bacteria to abandon any free-floating planktonic behavior and immediately anchor down, stick together, and adopt a biofilm lifestyle to protect themselves from the environmental stress.
And the measurable results of this chemical trigger are profound. When exposed to therapeutic concentrations of corticosteroids, the bacteria in these studies increased their total biofilm biomass by 1.6-fold.
The steroid literally causes them to build a larger bunker.
Yes. Furthermore, the exposure caused them to double their release of extracellular DNA, or eDNA.
Now, we usually think of DNA as just genetic code locked inside a cell. But in a biofilm, eDNA serves a totally different purpose. The bacteria physically spit out their own DNA strands to act as literal structural rebar.
Exactly, like rebarring concrete.
It weaves through the slimy exopolysaccharide matrix, giving the biofilm immense structural integrity and making it incredibly sticky.
So by pumping out twice as much eDNA, the bacteria are constructing a thicker, structurally superior fortress. And the most critical aspect of this entire process is that the bacteria do not need to genetically mutate to achieve this resistance.
They don't.
No, they simply use the physical presence of the steroid molecule as an environmental cue to rapidly adapt to a chronic, persistent phenotype.
Which is mind-blowing. The very drug a patient is taking to calm their systemic inflammation is being intercepted by the bacteria, interpreted as a direct structural threat, and used as a molecular trigger to build a thicker, stronger fortress.
It really highlights how smart these organisms are.
The medication is blinding the body's cellular defenders while simultaneously handing the bacterial invaders the chemical blueprints and the raw materials to build an impenetrable bunker right on top of the dermal filler.
This raises an important question about how we handle the clinical reality for a patient sitting in a practitioner's chair right now, considering a penile or labial enhancement. When you combine the anatomical vascularity, the blinding of the M2 macrophages, and the steroid-induced supercharging of the biofilm, it creates an absolute perfect storm for the patient.
Let's walk through that clinical reality. A patient who takes a daily corticosteroid inhaler for asthma comes in for an intimate filler. Their macrophages are already stuck in that M2 warm towel phase.
Right.
The needle goes in, dragging in a few microscopic staphylococcus bacteria from the skin surface. The immune system is too suppressed to fight off that initial contamination, and simultaneously, the steroid diffusing through their blood and tissues is actively encouraging those few bacteria to rapidly form a thick, eDNA-reinforced biofilm right on the newly injected hyaluronic acid.
To make a bad situation worse, the systemic steroid is still performing its primary function, reducing inflammation.
Which sounds good, but
it clinically masks the early warning signs of the infection. The patient doesn't experience the localized redness, the swelling, or the radiating heat that would normally prompt them to return to the clinic immediately.
So it's totally silent.
Yes, the biofilm is allowed to mature and grow in complete silence, utterly undetected by both the patient and the physician.
Until it reaches a critical mass, or gets triggered by something like a dental cleaning months later. And when that delayed complication finally erupts, presenting as painful, hard granuloma nodules or a widespread aggressive skin infection like cellulitis in the genital region, The standard medical playbook gets thrown out the window.
Yeah, you run into a massive treatment paradox. Normally, if a patient presents with severe, painful, destructive inflammation, a physician's first instinct might be to prescribe a high dose of systemic steroids to rapidly calm the tissue down and prevent further damage.
But in this specific scenario, systemic steroids are strictly contraindicated. If you introduce more steroids to calm the inflammation, you will just further suppress whatever remaining immune response the patient has, and you will directly feed the biofilm stress response, causing it to fortify itself even more.
You will actively pour gasoline on the fire.
So the clinical protocol becomes incredibly grueling. Because the bacteria have physically anchored themselves to the foreign hyaluronic acid, you cannot just target the bacteria. You have to completely remove their home.
Right, you have to break down the bunker.
The practitioner must inject an enzyme called hyaluronidase into the area, which enzymatically melts and dissolves the hyaluronic acid filler, effectively destroying the foundation of the biofilm bunker.
And dissolving the filler is only the very first step. Because that 3D biofilm shield has been fortified with extra eDNA, standard first-line antibiotics won't penetrate it. The patient requires massive, aggressive, prolonged antibiotic therapy.
Like how massive?
The clinical guidelines often dictate a combination of two broad-spectrum drugs. Usually a macrolide like clarithromycin, which is specifically chosen because it is highly lipophilic and penetrates fat and deep subcutaneous tissue, incredibly well paired with a powerful clinolone.
And the patient must endure this heavy-duty dual antibiotic combination for up to 6 full weeks. 6 weeks of aggressive systemic antibiotics combined with dissolving an expensive cosmetic procedure just to clear an infection from an injection they received a year prior.
Which is brutal.
This is exactly why pre-procedural screening cannot be taken lightly. The literature clearly states that patients on immunomodulators or immunosuppressants face a known 28% complication rate, with the vast majority manifesting as these delayed, deeply entrenched nodules.
And it really shifts the responsibility to the clinic, too.
So what does this all mean for you listening? It emphasizes the absolute, non-negotiable importance of full medical disclosure to any medical practitioner, even for an elective cosmetic procedure. It is incredibly easy to sit in a clinic chair and think, my asthma inhaler or my rheumatoid arthritis medication has absolutely nothing to do with getting a localized dermal filler. I don't need to put it on the intake form.
But they absolutely do.
As the biological data shows us, the microscopic interactions between your daily medications and the invisible bacteria on your skin can be devastating.
Because the human body is not a series of isolated systems, it is a deeply interconnected chemical ecosystem. You cannot alter one systemic variable like dialing down global inflammation with a corticosteroid without causing a massive ripple effect that alters everything from localized tissue healing to the genetic behavior of resident bacteria.
It's all connected.
Completely. Practitioners absolutely must know your complete chemical history to accurately assess your risk, especially when injecting foreign material into highly vascular, high-stakes areas.
We started this deep dive looking at the unique, high-stakes anatomy of intimate dermal fillers, the complex highway construction compared to the simple cul-de-sac. We journeyed down to the cellular level to watch how normal resident skin flora, pushed beneath the surface, transition into stealthy, dormant biofilm fortresses.
Right.
And we uncovered the incredible double-edged sword of everyday corticosteroids. Medications that simultaneously put your cellular bouncers to sleep while actively handing the bacterial invaders the blueprints to build stronger walls.
It serves as a phenomenal, humbling reminder of how much we still have to learn about the intricate host-pathogen relationship. Our modern medical interventions, as advanced as they are, can still tip the biological scales in ways we never anticipated.
Which leaves us with a final, slightly unnerving concept to ponder. We just explored how ancient microscopic bacteria have evolved the sheer mechanical ability to eavesdrop on human anti-inflammatory medications. They physically feel the chemical stress of our synthetic drugs and use it to strategically fortify their survival. So it makes you wonder if they're reacting to synthetic fluticasone or budesonide, what natural chemical signals are they listening to? When we experience intense psychological stress and our bodies flood with natural cortisol, are the bacteria inside our gut, on our skin, and in our tissues eavesdropping on that stress?
Are we signaling them ourselves?
Are our daily emotional states accidentally acting as a dinner bell or a chemical text message, instructing our microbiome to drop their current behavior and prepare for war?
It completely reframes who is actually in control of the ecosystem. The bacteria are always listening.
They really are. Thank you for joining us on this deep dive into the complex, murky waters of immunology, microbiology, and aesthetic medicine. Keep asking questions, keep challenging the obvious, and stay insanely curious. We'll catch you next time.